we're asking patients in the therapy to do something that they've been terrified to do throughout their life, which is embrace being imperfect, try, disclose things about imperfections, present yourself as a vulnerable person to the therapist. So the metaphor I use is that, in order for that person to feel safe in the world, feeling flawed and defective, the way to feel safe in the world is by trying to be perfect or trying to appear to others as if they're perfect. So showing themselves or allowing themselves to be imperfect is incredibly dangerous. That's the feeling they have. That's what vulnerability is. So if you think about any of us going through it, we have learned all kinds of things on how to feel safe in the world. So you probably only had to touch a red hot element once. And even then, you may not have had to learn to touch it once. Maybe you observed somebody else touching it. And so following that, you will spend a lifetime of when you see that red hot element, you're going to keep your hands away from it. And it's going to work wonderfully because you're not going to get burned. You're not going to feel the pain of that. Well, if I come to you and say, Dan, I'm going to take your hand and we're going to go into my kitchen and I'm going to turn the element on and it's going to be okay. I'm going to set your hand on there and you're not going to feel any pain. You're going to say, I'm out of here. And it's that kind of task that we're trying to do with these folks, is trying to create a situation and a context where the person might consider, based on the relationship with that other, maybe I can trust in something different than I have believed all my life, different than the behaviors I've exhibited all my life. And so that constitutes a therapeutic alliance to me, is to create that kind of safety for the individual, that they can do things that they have been avoiding, they've been terrified to do throughout their life. And so I agree with you 100% that it's become so cliche when you say therapeutic alliance. But for me, that's the kind of connection that I'm talking with. So deep trust in the therapist, a connection. The patient has a sense that I matter to the therapist. The therapist has a real, genuine, legitimate interest in me and in trying to be helpful to me. So the Rogerian pieces, absolutely, but that epistemic trust as well, that some of the psychoanalytic folks talk about as well. That's the context to learn these new behaviors in.
Right. That it is only within that context that the corrective experience can occur. That I can right. And this is I wasn't really trained in any sort of dynamic sort of framework, but this is something I've definitely taken from, which is that the dynamic folks are so like. I think this is something that many people from other orientations, I'm particularly maybe more cognitive behavioral sorts of orientations, that the value of bringing it into the session, right? So like that you can, right, we can use this here and now to process
100%.
And to like this. I mean, it's such a one, I mean, it's so available, that like I can use me and us to make this treatment work, that this in this relationship. And anyway, but obviously there are lots of cognitive behavioral folks who do integrate some of that, but I think that the dynamic folks they're much more overt and and have decades of experience and thinking and practice doing these sorts of things.
And refinement. I mean,
yes.
I like that you said decades, because that orientation has been under attack for 100 years, but it's still one of the most common theoretical therapeutic orientations that people have. And there's also an incredible amount of research that within that domain of psychoanalytic theory, psychodynamic therapy, that people often are totally unaware of, and they're told there's no research, but there's a massive amount. But there's also been 100 years of refinement, of thinking about, of shifting and changing, and seeing what works in treatment, and these subtle changes that occur. So yeah, there's a rich history of that kind of work that really bears on being effective for people. And there's a good deal of research that suggests that it is just as effective as any of the other treatments that are out there.
Well, and I think that in listening to you talk, that I think that if you're a thoughtful, sort of flexible person from almost any other orientation, you can take everything that you're saying. Like, yes. I feel like this is not, because you're in that tribe, we can't fit, that this is, everything that you're saying, I'm sort of taking my own jargon in my head and plugging it into the clauses that you're using to be like, oh, yes. Well, this is it, this is that. And that.
Well, I think that it's that the good clinicians in the real world, this is not new. When you work with people every day and where they're struggling through their difficulties, psychotherapists, good psychotherapists, learn from this. And so when somebody like me talks this way from a psychoanalytic perspective or psychoanalytic, like you said, they just say, yeah, I see that. It's in academia, in the academy, where people don't work every day with people and patients, that it gets polarized, and there's this misrepresentation of what it is, and these kind of wars sort of exist. Right. But I would agree. I mean, there's some research that suggests that the seasoned therapists, irrespective of their orientation, have way more in common in what they do than the beginning therapists coming out of the academy, if you like, that they're really different in terms of what they do. But over years, as you learn how to actually do the work with people, we all kind of become very similar. Might do different things, but we think about people very similarly.
I'd be curious, I don't have any data on this, but I felt like since when I started training until now that there's been a shift where there's been less sort of tribalism in the different orientations and approaches than there used to be. Do you get that sense, or do you feel like that, or not so much?
In the clinical world, I feel that. In the academic world, no.
Okay, interesting.
I think it's still there. It's a little bit more subtle, but it's still there. I see it with my colleagues. It's subtle. I actually started with my students and other students who have real interest in being trained psychodynamically. In my program, I've started a group because students would come to me and say they feel marginalized. Because they'll talk about things in a slightly different way, and they'll feel marginalized. And what would happen is I decided it's not a support group per se, but it's a group to be able to remind these students who are doing my practicum in another psychodynamic person's practicum that the way you're thinking is fine. It's very different. It's very potentially threatening to other people or antagonistic to other people, and they have no problem voicing those things. But and just to remind them, no, that come and we'll chat once a week about whatever you need to provide this sense of, okay, no, the way I think about things, there's legitimacy to it, that I can do this. So I maybe there's less, and actually there certainly is less in our program because we train a good number of students mainly in a psychodynamic orientation now. But there's still elements of it that are there. And I think across the country, for example, in counseling and in clinical psychology, internships, I work with my students to try find internships where they're going to get additional psychodynamic training and not just focused on CBT or DBT, cognitive behavior therapy or dialectical behavior therapy. And we have to kind of work at it.
Interesting. Interesting.
So,
Okay, so let's jump. So
yeah, kind of got off the
yeah, no, I took us off the. So when we in getting into the treatment stuff,
Yes.
so two potential questions, or you can take it wherever you want. So one is I'd be curious to hear your thoughts because you've done work at both the individual and the group level in
Yes.
terms of, and then you also talked about earlier, and I think it's worth talking about sort of transference and countertransference.
Sure.
So we could take one of those two avenues
Okay.
into it, or a third if you have another way you'd want to go.
Well, let me just talk broadly about the whole theoretical approach to doing therapy. Um, I've sort of alluded to these two driving motivational force, that need for esteem or cohesion and a need to belong. So the idea here is that um, when we're working with perfectionistic people, we don't do diagnostic work, we do clinical formulation. So we want to create a model of each individual, and each person has a completely unique and idiosyncratic model of how they function and how perfectionism plays a role in their life. So one of the things we want to address is within this model is what are the relational needs that are not being met for the individual. And really, we're talking about usually, especially with perfectionism, this need for self-esteem or self-cohesion and a need to fit and belong in the world. And so we want to understand those relational needs. We want to understand the types of when those needs aren't met, what does the person experience affectively or emotionally? And that's the pain piece of this. And everybody will first say depression, anxiety is what they experience. But when you dig into the depression and anxiety, you very often get to painful affect, reflecting I'm not being good enough, I'm alone, I'm disconnected, I'm isolated from the world, I'm reprehensible, we get to those relational pieces and the pain connected with that. So we have the needs that are not being expressed, we have the affect. And then with that affect, we try to cope with that affect somehow. And these folks have coped with the affect that, well, if I'm perfect, that'll reduce the affect. But if I'm perfect, it will also meet the needs. So we work from these triangles. It's hard to describe them verbally without slides and that sort of thing. But the idea is I will have these relational needs that are not being met. I don't fit. I don't belong in the world. And that is deeply painful to me. In order to deal with the pain, I need to do something. And so if I have the sense that if I'm perfect, then I'll meet those needs, I'll fit and belong, and it will take away the pain. Okay? So at a real basic level, we're trying to create a model that's with the person's own life in terms of those needs and the affects and how they are trying to be perfect or appear to be perfect, as well as these other things that people will do because they're complex. And so there's these two triangles that we put together and describe. So that's how the person functions internally. These needs aren't being met, painful affect, and then the perfectionism serves the purpose of reducing the affect and the promise of meeting the needs. We also look interpersonally in the person's world. So we look for interpersonal patterns that the individual has. And these usually arise from early relationships where the person learns, in order to feel like I fit in my family, I will need to be the perfect caregiver. I will need to actually be the perfect parent to my parents who are useless, or I will need to be perfectly invisible. And so they have these patterns that they learn to try to cope with the early life. And those patterns show up not only in their past relationships, but also in their current relationships. So you'll see a pattern you try to identify patterns that were there early in the person's life that show up again in their relationships with their workmates, their romantic partners, their friends. And we try to identify those patterns with the assumption then that those patterns are going to show up in the therapy. They're going to show up with the therapist. So if the person needed to be, the perfect student early in their life, in their family, that was the way to create safety. It was the way to create a sense of a promise of affection or love or mattering. Then you're going to see in their current relationships, at school or at work, they're going to be the perfect worker. They're going to be the perfect student in that context to create safety and to create a sense of, okay, I matter, I'm good enough, I belong. And then in the therapy, you're also going to see trying to be the perfect patient, trying to exhibit the same kinds of things in the here and now, the therapeutic alliance.
And so these interpersonal patterns, these are things that I do to in response to the pain, in an attempt to get my needs met.
Well, in response to the pain and in order to try to get the needs met. Yeah.
To turn down the volume on the pain.
To turn down the pain, first off,
Right.
but also with the promise of meeting these needs.
Got it.
So it serves two purposes. And that is exhibited in early relationships, doing, the perfectionism, the trying to meet the needs in a particular way. You'll see them in current relationships, and then you'll see them in the therapeutic in the therapy itself with the therapist. So that would be the transference. That would be so the real work of therapy in this is in the here and now. And you alluded to that earlier, that when those emotions are right in the room with you, then you can actually work. It's not an abstract working. It's a working right here and now, with that content. So,
and as we alluded to earlier, the interpersonal patterns, those things that I'm doing, they don't actually work.
No, they don't. Right. No, they really don't. And it's kind of like the way we understand it is, if I've learned that if I come across to you as absolutely perfect, the model I have is, if I come across to you as flawless and perfect, then you will care for me. Then you will like me. Then, I will matter to you, until you actually start to interact with me. And I'm not disclosing anything too personal or imperfect in any way. So I'm pretty distant. I'm not demonstrating anything to you. Again, so I'm pretty distant. And how do you, when you and I interact and you're interacting with me being very distant, eventually you're just going to pull away. So here I am trying to appear perfect with the model that you're going to care for me. And the more I do it, the more you're pushed away. Or I can also tell you how wonderful and perfect I am and not let you get a word in edgewise, because there's one more thing that I'm perfect at that I need to tell you about. And this is a model of, well, then you will respect me, then you'll care for me, then you'll think I'm amazing. And what do you actually feel?
Yeah, I'm annoyed.
Get away from me. And that's the model. That's the neurotic paradox, that I am driven to obtain a goal from you by engaging in this behavior with the absolute belief that if I do this, you will care for me. But I actually create the thing I fear the most, which is your rejection or your pulling away or your distancing.
Yeah. Would it make sense to jump into your thinking about group for folks with perfectionism?
Yeah. Well, we do group work, and we've done most of the research we've done is on within groups. Group is psychodynamic psychotherapy within groups. It's psychodynamic interpersonal psychotherapy within groups. I'm really sort of feeling like it might be the treatment of choice, actually, for perfectionistic individuals, because of those powerful relational needs. Now, it is often terrifying for perfectionistic people to think about going into a group to do therapy. It's pretty anxiety provoking for those folks. Intriguingly, once they start, folks will talk about it's the first time that they've ever had other people who, one, they see as similar to themselves and really can understand what they're actually going through. And so they actually, for some of the first times in their lives, feel a part of a cohesive group. And so it's very, very powerful that way. But at the same time, in the kind of work that we do, it's all based on the same sort of theoretical model. We want to get to the relational needs that are being expressed or requested or invited by people in the group, get them to articulate the needs, and they'll get feedback from other members about, well, you want to come across and you want to be accepted into this group, but all you talk about are your straight A pluses in school or all the awards you meet, and that distances everything. So they get this very powerful feedback from these other people in a context that is safe, because we spend a great deal of time making it a safe, supportive context for people to be vulnerable, but get this kind of feedback from these other people. So the research that we've done with the group shows very good effects on changing perfectionism, as well as a lot of symptoms and other problems that people have. The more we kind of look at it and do it, the more I'm thinking that it absolutely is potentially the treatment of choice, but certainly a powerful treatment for perfectionism, and maybe a nice adjunct to individual psychotherapy that we do with perfectionism as well.
So is it reasonable that, whether it's group or it's individual, that you would have to spend a substantial amount of time just throughout trying to facilitate helping clients see how unhelpful this is, how
Yes.
they're not, okay.
It's not having the effect. In fact, it's often having the opposite effect. And it's not because you're flawed and defective that people are pulling away from you. It's that the way you're dealing with feeling like you're flawed and defective that people are pulling away from you. Does that make sense?
No, it totally makes sense. I'm thinking about what I'm thinking about as you're describing this is just how, just rolling a boulder up a hill, how, I'm thinking about the actual person, right? I'm thinking about an actual human being who's coming in and I'm talking to. And so that I need to create this safe context, and I need to, most likely, you tell me, you correct me, but you would have to really kind of, you've been very direct in our conversation, and I've said, oh yeah, that makes sense. Oh yeah, that makes sense. Oh yeah, that makes sense. But when you're actually working with a real human being who's suffering,
yes,
with these, these challenges, that you probably aren't that direct, because if you were, it wouldn't be helpful.
No.
And that it's just how trying to shift, even just trying to get them to see and feel, oh yeah, that is how challenging that would be.
It is challenging. It's hard work with people. The metaphor I use, I like that you said you can't just tell somebody something and then they're going to change their behavior, they're change aspects of their personality. I liken it, I wrote about this in a book. It took me a long time to kind of figure this out. But I liken this kind of psychotherapy to learning how to ride a bicycle. And if you've never ridden a two-wheeler, Dan, and you decide, today's the day I'm going to get a ride, learn to do this, and you being a talented academic, very intellectual, you say, I'm going to hire Lance Armstrong. I don't know why I thought of him, but anyway, Lance Armstrong to come and do a workshop. He's going to do a lecture. He'll have slides. He'll talk all day long and teach us about, well, you put this foot there, you put that one there, you contract this muscle, and so, and you learn all this stuff and you study and you write the multiple choice exam, you get 100%, and you know it flat. And then you go out and you get on the two-wheeler and you fall over. The way to learn to ride a two-wheeler is actually interpersonally. Most typically you have somebody else who's there holding the bike. You get on, they encourage, they help, they push, they guide you, they let go, they grab onto again. You're wobbling, you're getting, you fall down, you get hurt, you get back up. And eventually, through the process of experiential learning, through experience, you progress through falling over the moment you sit on the bike to navigating through traffic, watching signs, being aware of other drivers, being aware of the cow in the field, to doing this incredibly complex thing that you can never learn by studying it, by the intellectual avenue. It's the experiential piece. So the teaching and the learning is within that therapeutic alliance to have the experience of being able to do things that they've not been able to do before, and experience that there was not this calamity, that the world didn't fall apart, I didn't crumble, I made it through. And so that experiential element is sort of the best way I have of trying to explain how it is that people learn in a more psychodynamically oriented therapy.
In group, do you think that clients, by seeing this in other people, are able to, in the group, or by seeing it in other people in the group, do you think they're able to make sense of it more quickly, more effectively in themselves?
I think what they'll do is they'll see the effect. They'll see the effect of what that person is doing.
The negative, like the consequences on themselves.
I'm sorry, let me say it a different way.
Yeah.
I think you're right that seeing other people take those risks, they may learn about themselves as well, that they have that. And they may, just by seeing a person take a risk, they may think, okay, well, maybe I can do it. I think what's more powerful is when that other person takes a risk and they see the effect on the group of what happens.
Oh.
Is people, I mean, one of the things that is lovely to see in patients, especially patients who have the belief that if I really let people see who I am, they'll run screaming from the room. So I can't reveal who I truly am to anybody because it's just too terrifying. I'm sure you've had patients like that. And then when we help them get to a place where they actually do that, they discover, oh my God, when I do that, I just get closer to people.
Right.
That's a moment that I think is hugely powerful for those folks. And in group, you can kind of see that occur. Now, of course, you can't. You have to teach people that they have to vet who they're going to disclose to.
Right.
But if in that context, if they can be more vivid, they can do things they've never done before that are so terrifying, and see that the effect is, oh, that's how I get closer to people.
Right.
That's how I matter to others. Not by being perfect and standoffish. It's about maybe being more genuine or more authentic.
Yeah. Is other-oriented perfectionism, do you think that, now obviously you said that you would do a case-specific conceptualization. So each client, each makes their own conceptualization. That makes sense. So there's obviously you're allowing for the nuance of the individual to be playing in here.
And their history.
Of course, all that, right? And so, and do you, when you think about other-oriented perfectionism versus the other sort of two sort of trait level, do you think about it differently in terms of what you need to do clinically, or not so much?
Not so much, because I'm looking underneath.
Right.
What are the relational needs that are not being met, and how are they trying to meet them? Now, I guess there may be some the content of what we may talk about might be slightly different for somebody who's more other oriented than socially prescribed or self-oriented. But it's really working at that relational level in terms of what they're doing to try to meet those needs, the lack of the meeting of those needs of feeling okay and good enough, and that what's important about the drive. What are you trying to do by engaging in all these behaviors, and what are some other ways to meet those needs? So it's kind of to help them articulate what the needs are that they don't have, and the pain of all that, and then helping them move to a place where there's maybe more adaptive ways to try to meet them. As I said, by doing some things they've not been able to do, which is maybe disclose a little bit more of themselves or take risks and showing themselves to be authentically who they are.
Right.
That has the opposite effect of the model they've been working with all their life.
Right. So one of the things I was wondering about before, when I was thinking about this conversation, was I know that there are some CBT folks who do perfectionism focused intervention stuff, and I was sort of curious what your sort of sense of that is, how it relates to your work.
Sure.
Yeah.
Yeah, there are some people who have done who conceptualize perfectionism quite a bit differently than we do. First off, and then conceptualize it as primarily a cognitive or attitudinal kind of variable. And then appropriately, if that's the way you conceive of it, it makes sense that a cognitive behavioral therapy approach might be helpful. And there's people who have done some research on that and done a variety of studies looking at what they call it CBT, but the way they define CBT can be like a protocol, kind of similar to the way Beck talked about it originally, but then other things like read a book, do some psychoeducational stuff, and calling all of that CBT. And they presented some research and did some meta-analytic work, which was fine. I thought, this is great. There's a group of people interested in trying to be helpful to these folks who are really hurting. But as we began to do more of the randomized control trials and some of the other psychotherapy outcome work in the psychodynamic approach, we looked very carefully at that work. And there was a meta-analysis that they published, and we thought, oh, well, they forgot to do a couple of things. But what we'll do is sort of a fundamental thing that you do in science is simply replicate. So we took all the studies that they use in the meta-analysis and we reanalyzed them. And what we found was a less than optimistic picture of what they were doing in terms of CBT. So most importantly was there are certain elements of perfectionism that are particularly pernicious.
Sure.
And so we talked a little bit about other oriented, you saw that, but also socially prescribed perfectionism is really pernicious in terms of depression, anxiety, a bunch of different things, including early death, by the way, but suicide. And we found when we replicated this CBT for perfectionism work, that it didn't have any effect on the pernicious elements of perfectionism. Did change some of the cognitive stuff, which just made sense to me if you focus on the cognition, but it didn't change the traits and it didn't change the perfectionistic self-presentational elements, which we thought was, on the one hand, really important to put out in the literature, that, this is not touching those important pieces. But then as we looked a little bit closer, we also saw that often 50% or more of the people who were enrolled in those programs dropped out. And so we thought, well, okay, it has an effect on the cognitions for some people who stay in therapy, but if 50% of them drop out, then maybe you need to do some other pieces in terms of the treatment. And so there were a variety of things that just, it was less optimistic than I think was being presented And again, there's a little bit of pushback from that group, which is fine. It's just the way it works. But one of the accusations was they were saying this is how bad science produces effects, and we thought that that's very funny because replication is a fundamental pillar of science, and to complain that we used exactly the same data they used and replicated, found some things that they forgot to either address or focus on or even report. There's that sort of piece that sort of fits in there. So now it's not to say that the treatment that we've developed is perfect or anything like that, but what we did do is we have been able to demonstrate that it does change effectively the pernicious elements as well as the cognitive elements, but it's not perfect. And so the research we're doing is not to say we have this treatment and we're going to do all this research to say it's excellent. We're doing the research to say, okay, this works, this doesn't work as well. What can we do to shift and change the treatment so that we're getting better effects in some of the things that don't work as well? So we're looking at it less as research to demonstrate that the treatment we've developed works, and research more on, okay, well, what works and what doesn't work, so and how can we try to make it better? So it'll be a series of outcome studies that we're doing while we're tinkering with the treatment and trying to make it better in different ways.
And that's with your dynamic treatment.
It's called dynamic relational therapy. It's a psychodynamic approach. I sort of spelled it out today in terms of some of the things that we do with it.
And is your sense, and we're just guessing here, but is your sense of maybe why some of that the CBT-based intervention wasn't as effective in terms of the pernicious stuff? Because it wasn't, I mean, in a way, it sounds like it wasn't focusing as much on those sort of or traits or personality-like kind of aspects of the patients.
I think it's because they didn't deal with the deeper relational, motivational variables. Because the CBT, in and of itself, deals with the surface stuff about thoughts and cognitions. We'll talk about affect, but they don't really go very deep with affect. It's more about the corrective thoughts or correcting. The scary part is with that and other parts of CBT is sometimes it's directed more at coping with perfectionism, or more broadly, like you've seen advertisements all over the campus and different places, learn how to cope with your depression, cope with your anxiety. And it drives me crazy. And my students always laugh because they see me, I want to rip those, say, why on earth would you use all these incredibly complex psychological interventions? Why would you use people who've been trained extensively in these psychological interventions just to help somebody cope with why aren't you working with what's causing so they don't experience the depression again? Why don't you work on the psychological causes of the depression or the anxiety or the perfectionism? So again, now it just reflects a psychodynamic way of thinking about problems, that if all you're going to do is treat the symptoms of something and try to reduce the symptoms, you're not being very helpful to people. It's like if you have a exceedingly distressing pain in your knee, hopefully when you go to your physician, you don't simply get pain medication to take the symptom away. Yes, it will be relieving. The pain's not there. But the whole point of the pain is it's a communication to you that there's something wrong in your knee. Pay attention, what's going on at the knee. Now, a physician won't just give you pain. They're going to poke around in your knee and try to figure out what's causing the pain. And what are they going to treat? Well, they might give you some relief with pain, but they're really going to treat the cause of the pain. So in these interventions that help you cope with That's why it drives me nuts.
So is it? This is. Let me do a extremely precise summary of some of what you just said, which is because this comes from interpersonal. Because this comes from the interpersonal. If we can attend to the interpersonal in therapy and influence that, we're able to attend to the cause. That wasn't gracious at all, but
No, the putative cause in what we're talking about today, the putative cause of the existence of the perfectionistic behavior, which results in really, all of the depression, anxiety, suicide, all the negative impact of that. But if you try to get at the cause of the perfectionism, it's like pain.
Right. But the cause is interpersonal.
Well, the cause is relational and it's
Relational.
motivational.
I'm sorry, relational.
Relational, motivational. A need. I have a need to feel like I'm okay, that I'm good enough in the world. I have a need to feel connected to other people. I have a need to feel loved, to love. I have a need to be lovable. And it's those needs, the fact that those are not being met from our theoretical perspective, that's what's causing the existence of the perfectionism. And then with the perfectionism comes all these other problems. So if you get at the cause of the perfectionism, you get at meeting those needs in a different way, the person, there's no need to be perfectionistic anymore. That's the model. It's like if I fix the problem in your knee,
right,
the pain's going to go away on its own.
Right. Yeah. No, that makes so. I'm trying to think about where. Okay, so let's do this, and then if there's anything I'm missing, please jump in. But one thing I did want to ask you, because I know that you don't do work with kids, right?
I have a new graduate student who that's exactly what we're starting to do.
Well, okay,
is take that treatment to work with kids and adolescents.
So the question I was going to ask you, because I wanted to ask you about resources, and then what I'll do is I'll take notes of resources, then I'll put them in the show notes. So that way, if anybody but one of the things that I was wondering is, even though your work historically has primarily not been with kids, you must get parents who approach you who say, my kid is, and it might not be what we're hesitant to categorize somebody as, a kid as a perfectionist, but we certainly could say that certain kids have would show some indications of perfectionistic traits that are consistent with this framework or this framing.
There's a lot of research on perfectionism in kids. We just published a book last year summarizing some of that work and summarizing some of the basis of the models that we might use to treat perfectionism in kids.
Okay, so what's the book? And I'm just, because I think that there's going to be a listener who's going to say, like, I could really use looking at a resource or two for this.
Do you want me to hold up my books?
That'd be great.
Okay. Well, this one outlines a lot of the stuff that I've been. Now, for some reason, I have a mirror image of it on my.
No, it looks great
on my screen. Okay, it's a 2017 book on perfectionism. Kind of talks about everything we talked about today, more in depth. But my colleague Gord Flett and I we just published this last year. Where am I here? Perfectionism in Childhood and Adolescence. And so it's less. The first book is more of a clinical book. This is more of a not so clinical book, but a lot of the research that's on there as well. I'm happy to send you those references if you want to.
I will look if I for some reason I can't find them, which I can't imagine. But what I'll do is I will look them up and I will hyperlink them, so that way if people are listening, they can just click on it and go right and there.
They're on my website as well. It's easy to find my lab website.
I will link that as well in the show notes. Yeah. And are there one of the other questions I wanted to ask you was. Particularly because we're going to have practitioners in training who are listening, that you develop several measures.
Oh yeah.
And like, what would be the ones that you would point that you tend to point clinicians to?
Well, the measures that we use for those three broad domains, the
Uh-huh.
traits, the self-presentational elements, and then the intrapersonal elements. Those are available on my website, with the exception of one, which is multi-health systems owns one of the trait measures. But if it's on, they can just go to my website that says measures, and they can see. And I provide norms, and I provide other than the MPS, I provide the measures themselves, adult versions and children versions for kids as well. So,
And you have self-report measures, and you also have clinical interviews, right?
I have an interview. Yeah,
Okay.
we've used it less. The self-report measures tend to be used a lot more frequently.
Okay.
So
Okay. Great. Before we end, is there anything else that you want to make sure that we hit? I feel like this has been a lot, and I think that even there are other avenues, but I'm like, no, I've kept you for long enough.
I mean, I've been doing this for over 40 years, so there's a lot of things I could talk about in that domain. Whenever I talk about this, it usually resonates with people either personally, there's bits of it that make sense to themselves or loved ones, but also clinicians. Often clinicians will hear this and they'll go, "Oh, I recognize that. I never thought about it in that way, or never put it in that context." And so each time I do these sorts of any sort of presentations, people do resonate with it, and it kind of makes a great deal of sense to them. I mean, there's that piece to it that one of the reasons I've been doing research on it so long is because it's intriguing as you go a little bit deeper, and you just see it more and more. And it's not that every patient I see is perfectionistic, but you see elements of these pieces in people's functioning, and especially the pain that they have, really about feeling okay about themselves or feeling okay about how they fit in the world. And so they're really foundational pieces that are that I think are fundamentally painful parts of living, and we always try to deal with those in different ways, and people are more or less effective in dealing with that. A lot of the people that you and I see in our practices are people that maybe just have ways of trying to deal with those issues that are less effective, or most commonly were really effective at one point in their life, and now it's not so effective anymore, but can't just stop and do something different. So I mean, that's one of the intriguing things, is it does resonate with people. And there's a large literature on perfectionism. I had great hopes as that undergraduate of publishing the first empirical study on perfectionism. It was on perfectionism and depression, and it was my honors thesis. And in the process of trying to publish it, another Canadian researcher at the University of Regina published a paper on perfectionism and depression. So I wasn't the first, but that's okay. But at that point, it's kind of burgeoned now, where there's thousands of articles on perfectionism, and most especially the problems that that it's connected with people. So.
Can we end on a real quick story? Can I give you just a real quick? So you and I were at a conference that we happened to go to together, or we happened to both be at.
Just a couple of months ago.
Yeah. Society for Psychotherapy Research. And we were both in a session, and you were sitting somewhere else. I don't even know if you know I was in there. And on folks who were working on a resource, which was group, basically empirically supported group psychotherapy. Do you remember this?
Okay. Yeah.
And which I think was it seems to me like, oh, that's a great endeavor to try, and all of the treatments were for DSM diagnoses for, and you raised your hand and you asked the question of you asked very politely, which was something to the effect of, would you ever consider having a treatment or looking at treatments that aren't for disorders, problems, challenges, whatever, that aren't in the DSM? And they sort of said, I mean, I took their response as like, yeah, I guess. I mean, I didn't think it was dismissive. I didn't think, I thought the response was fine. But when you said that, I was sort of sitting there, and I've been over the last, I don't know, 6 months or so, been paying maybe a little bit more, paying a little more attention and sort of reading up more on more explicit critiques of the DSM and that sort of thing. And I've always sort of put DSM in its place in my head. That was part of my training. It wasn't a Bible or anything, but one of the things that I had read that really stuck with me is just sort of, the DSM is one framework. It's one approach. There's nothing, it wasn't handed down by God. Moses didn't get it. There's no, it's one way of looking at things. Mm-hmm. And when you said that, what I was thinking, when you said, I was like, yes, this is a person, who has devoted decades to studying and developing tools, empirically supported, as well as clinically supported, but in refining this challenge, this very real challenge. And as far as I can tell, perfectionism, as you conceptualize it, measure it, that it is no less valid than any other category in that big book, being the DSM. It is no less valid, right? But it goes in a different category. And I was thinking, this is exactly what we want. Like, this is exactly how we should be thinking flexibly about this, which is that this is this challenge that people have. It is pernicious, and it is,
it's transdiagnostic.
Absolutely. But in the same way, it's just a different category. I mean, it's just like we could have, the perfectionism could be in a different book that would be just as valid as the DSM. And, this construct is just as valid as, and many more valid than many, anyway, it just really stuck out to me. It's just like, and this is not a critique of the people who were doing the work they were doing. This is a larger critique of the field, which is, what the hell are we doing? Not really, whether it's systematically not including or systematically excluding stuff like this. And I do think there are lots of things that should be excluded, and I'm comfortable. I've heard people argue, oh, we should create this disorder and that. I'm like, really? But we don't need more disorders. We don't need more. It just really hit me when you said that, and it stuck with me ever since, of like, this is the perfect example of one of the real problems in how we have taken and run with the DSM, is that stuff like this does not get included when, like, we are not helping clinicians or clients by not including this in these. And anyway, that's my soapbox, but I just wanted to say that. So
thank you for that. I mean, you're talking about something that I speak a lot about, which is the philosophy of a DSM approach versus, like, rather than focusing all of our clinical efforts on sets of symptoms, which are surface things, and directing all of our clinical attention on the surface things, the symptoms, you need to direct your attention on the underlying causes. So the focusing on the surface is a Kraepelinian perspective, hence the DSM, the neo-Kraepelinian perspective. Underlying causes is actually a psychoanalytic perspective. What are the things underneath that are producing the symptoms? This is what RDoC is trying to. So when DSM-5 came out, and there was all that furor from NIH saying, we're not going to fund DSM-based disorders anymore. We're instead going to look at the underlying causes. That was the furor. And I was thinking, yes, finally, We're going to deal with the thing. We're going to deal with what's going on in the knee, not just try to get rid of the pain in the knee. So you're speaking my language when you say those. And to be honest, I guess I guess it was my research that probably influenced the way that I think about that. To us, I never thought about doing the research on perfectionism from that perspective, but that is what I learned by doing the research over the years, and especially doing the clinical work over the years. It doesn't help people very much to cope with things. We need to try to get rid of the things they're trying to cope